So I have 15 minutes, and in 15 minutes I try to see if we can learn why are we imaging the eye, what are the common imaging modalities that we use in patients with uveitis, how can we grade vitreous haze, am I missing anything by not imaging the periphery, and then significance of focused imaging. I have around 75 slides and 15 minutes, so pay attention. You don't need to take notes. There will be, I will be sending the PDF of this presentation out. So why do we image the eye? In the good old days, all clinicians used to rely on their examination skills to document pathology. And in addition to that, they relied on their drawings and sketches and ever-declining memory to document what the lesions were, what the pathology was, and as the patients keep coming back, they kept looking back at their clinical charts. However, imaging nowadays has made it extremely easy for us to objectively quantify and objectively document certain pathology or certain aspects of the diseases. There are some imaging parameters and modalities that are commonly used. The first one being color fundus photography, OCT, and we're now talking mostly about posterior segment and pan-uveitis. Fundus autofluorescence, OCTA, fluorescein angiography, and some adaptive optics imaging as well. However, we'll only focus on color fundus photos and OCT for today. So, vitreous haze, that's the first thing that we like to assess on fundus photos. The haze, in technical terms, it's called blur. Anytime you see a blurry image, that's basically equivalent to vitreous haze. And the reason we see haze in these photos is because there is dispersion of light because of the proteins and a lot of the flare that is accumulated in the vitreous cavity. Although Kimura et al., they had proposed a 5-level scale in 1959. It wasn't until 1985 when Dr. Nussenblad and his colleagues actually published a photographic scale for us to compare our findings, and it was a 6-level scale at the time. This was later on confirmed and actually adapted by the Sun working group and became part of most clinical trials, pivotal clinical trials that you have seen so far. That's the 1985 manuscript. This is the scale. Now, some of you may have seen this scale either in presentations today or in your clinic. If has anyone seen it in the clinic? Raise your hand. Riza, okay. Some of you. So Riza has spent a lot of time with Kwan and JP, and so probably that's why he has seen it now. The reason for this scale was to, or for any scale for that matter, is to give us sort of a reference where we could not only quantify in some way, shape, or form, but also at the same time be able to longitudinally document the changes in a particular parameter. And the same is true for vitreous haze. The challenge with this particular scale is that it's not continuous. That is one of the things that has been brought up continuously, but this is the only scale that has been validated. The issue comes when people try to, in what we have seen so far, is a lot of people try to examine, try to look into the eye, and then they kind of look back and forth between the scale and the eye and try to match it with one of these. However, the actual manuscript came with definitions for each of these grades. So if you follow the definitions, you do not actually even need to look at the photographic scale to determine whether a patient has 4+, 3+, 2+, or 1+ vitreous haze. The way from a standardization perspective, since I also oversee some of the phase 3 uveitis clinical trials, and we have to try and standardize these scales, the interpretation of these scales across hundreds of sites. The way we tell everyone to interpret their vitreous haze is you always look at, do you see an optic disc? Is there any sign or any shadow of an optic disc or vessels? The answer is no, it's 4+. The moment you see some shadow of an optic disc or vessels, 4 plus is out. You are now 3 plus or below. With better visualization of vessels and optic disc, meaning you can see them, it's not just shadows, you can actually see some vessels, or even if it is very, very blurry, still you can see some, you are now in 2 plus territory. And the moment you can define the optic disc, the boundary of the optic disc, or and the vessels, now you are in 1 plus category. And then with 0.5 and 0, you actually have the retinal fiber reflex, and you have other features of the normal eye, of course, that you look for. Most of the patients who present to tertiary care clinics will be between 1 plus and 2 plus. It's very rare that at Stanford or Hopkins or Mass NU you see a 3 plus or 4 plus patient. Believe it or not, the most important image is not the ones that I had printed. This is the reflex image that we call it. This is the most important image for actually assessing a vitreous haze. And the reason for that is if we do not see a fundus reflex, that means we will not be able to actually confidently say what the vitreous haze was. The scale was designed for general global vitreous haze without any opacity in the anterior segment. So based on the definition that we discussed, as when you apply on this particular image, you have a blurry optic disc and vessels, both are blurry, but you can see both of them, so it's 2 plus or less at this point in time. Again, we always start with the fundus reflex photo and then take a look at the fundus photos. Same criteria applies. As soon as you see vessels and your optic disc, this is 2 plus or less. Now this is an example where it is the pupil is, and a lot of uveitis patients, we do see this, the pupil is constricted, there are synechies, or the pupil does not dilate properly, and what ends up happening is that we get images like these. Now these were labeled as 2 plus, but in both cases, if you actually apply the definition, you can see the optic disc very clearly, you can draw the margins of the optic disc, and what you're seeing around it, that's not haze, that's just the shadow of the pupil that's now, that is obscuring your view. So that's why this would not be, this is actually a normal eye. There is no vitreous haze. It's not a normal eye, but there's no vitreous haze. Similarly, in this particular case, the pupil was pre-constricted. If we just look at the fundus photo, this would be a 3 plus at minimum. However, when you take into account this particular pupil, this would be termed as ungradable. There's no point in grading vitreous haze in this particular patient. It would not be very objective for us to follow this patient. Another example, we do see vitreous, we do see a reflex image. Technically, we should be able to comment on the vitreous haze. The challenge is that with therapy, when this patient improves and this pupil actually dilates more, you cannot later on tell whether the improvement in vitreous haze was because of the improvement in the dilation of the pupil, or was it because of the activity of the drug. And that's why we again we try and find another way of categorizing this particular patient. As you can see, this looks like a 3 plus to 2 plus. There's another scale that was developed in Miami, Bascom Palmer. It's a 9-step scale. The way it was developed was they put artificial blur, so artificial lenses in front of the camera, and then took images. And these were designed to actually correlate logarithmically with the visual acuity. Very, very difficult to implement this in clinic. One, usually most of your patients, uveitis patients, have good vision. And two, there are no definitions for each of these grades. So you have to actually compare the images, and until we come up with a machine learning or AI algorithm that can do it more rapidly, it will be very difficult to implement a scale like this. So the advantages of such scales is that they've been validated, the regulatory bodies are also familiar with it, we use it. It's very easy for the NEI scale to be actually implemented, and gives us a very good way of documenting whether our patients are improving or not. The disadvantages, of course, haze doesn't exist in all your uveitis patients. 65% at best would have some form of haze. They are still subjective. You need quite a bit of practice to grade these images and get used to it. And then it's difficult to standardize the acquisition. Not all cameras, the flood elimination cameras versus the confocals will give you different intensity of haze. So the second question that we wanted to answer was, am I missing anything by not imaging the periphery? So this is a few years ago, I think it was 10 years ago, when Optos came out with the wide-angle imaging system. And here I have tried to superimpose different field of views that are available to a clinician, starting from a slit lamp all the way to a fundus camera to indirect ophthalmoscope, and then the wide field SLO, 110 degrees. I think the Spectralis has that. And the Optos was even larger than that, started giving us more information that we were not familiar with. The question was, what's the point of using this? Does it have any impact? So we did a study where we wanted to see the percentage of patients whose management was changed by the clinical exam alone compared with examination plus these wide field imaging. And our secondary outcome was the percentage of patients whose disease was determined to be active with the addition of each modality. So what we did was we presented a 60-degree image to the PI. Once they filled out the questionnaire, and there were 4 simple questions, about the status of the disease, whether they wanted to change, whether they thought that the patient had progressed or improved, and whether they wanted to change therapy for that patient. And once they had answered that, at examination, we showed them the first image, 60 degree, and then we showed them the larger, and at each step we made them fill out the questionnaire. This is the questionnaire about the disease activity and the status of the patient. We enrolled around 63 patients. 23 patients among these had retinal vasculitis as well. That group was analyzed separately. There was a good diverse group of diseases diagnoses that we had. We saw that on examination alone, disease activity was detected in around 38%. However, if you look at the last row, almost 67% with the addition of wide field FA, the clinician changed. It's the same clinician, and they changed their mind once we showed them the FA. At the same time, in around 51% of these cases, the clinician actually changed their management decision as well, based on the addition of the wide-angle imaging. So, in conclusion, we showed that wide-angle imaging does lead to significant differences in diagnosing not only vasculitis, but also it may affect the change in management. We do not know if that improves the disease outcome at this point in time, more aggressive therapy or not. I think that would be a more long-term and complex study. Both the manuscripts were published in AJO and then JOII. So another question that we wanted to ask was, hold on, my slide. So when we saw this, the vitreous, now that wide-angle imaging has started taking over, the issue was, can we detect vitreous haze on these wide-angle imaging systems? Because these are built differently. These are basically scanning laser ophthalmoscopes, and they're actually just 2 lasers in there. So we enrolled around 92 eyes, and clinically the mean vitreous haze in these eyes was around 1+. This is an example of an eye where vitreous haze, there was no clinical vitreous haze. On your right side, you're looking at the regular fundus camera. On the left, that's the SLO from Optos. And this is an image of where we, on clinical exam, it was 1+, and on Optos, this patient had some vitreous haze as well. This is an example of a 2+. We did show for the first time that it is actually possible to see vitreous haze in eyes with these wide-angle imaging systems, the SLOs and the confocals. The challenge is that it is very difficult to differentiate between 0.5 and 1 plus. So 2 plus and 3 plus, above those, it is easy to identify those patients with optos and with SLOs. But if you have image, question? Yeah.
I've always felt that the Haze you see from optos is just Haze. I always have a hard time distinguishing the Haze with Vitreous to PSC, posterior capsule to on the optos phone. Is there how do you do?
So optos has a function of you can actually do stereo images. That stereo image will give you some depth perception. That's one.
Okay.
But you're right, with the optos, for example, this particular image, we don't know where this haze actually is.
It's Haze, but
It's just haze. Yes, so that's why when we were grading these images, we really went for the definition, and we wanted to see if can we apply the definition over here, and based on that, we can say, so unless it is like a 2 plus or 3 plus, it is very difficult to actually see the vitreous haze. The other thing we noticed in some of our patients that, so when we saw vitreous haze, the entire image on the right side was covered, was vitreous haze. On the left side, on a 200-degree field, it looked like a blob. It was not covering the entire eye. So we weren't even sure if this is vitreous haze or not. It was through a lot of, when we saw quite a few of them, we realized, oh, since we are looking at a very large field of view, the vitreous haze is not actually in the entire vitreous, it's localized. And that, then when we started looking for that localized haze, we started identifying that vitreous haze, this that we see is a lot of dust and a lot of artifacts, but it is not vitreous haze. The vitreous haze and optos actually just sits in there. You can see it. If it is there, you will see it, that this is actually located in the vitreous at that point. So, significance of OCT imaging. There are 3 main things that you just need to remember. One, macular edema. If you see macular edema, and if your patients, you want to do an OCT so that you can then progressively, longitudinally follow that patient up, and if there's any increase or decrease with therapy, you'll know if your therapy is working or not. The second one is the characterization of lesions. So that's very important. In a lot of these white dot syndromes, we want to know where the lesion is, how big is it growing, is it not growing, what type of retinal layers is it involving, and then the third one is we can, in certain situations, actually in the absence of any chorioretinal lesions or any macular edema, we can see some retinal thinning, and that is possible to objectively quantify with OCT as well. This is an example of an 18-year-old man with idiopathic panuveitis and macular edema, was treated with tocilizumab 4 milligram for 6 months. And as you can see, not only the macular edema has decreased over a period of time, the vision has also improved. So this is an example of how we can serially image patients with OCT. On the right side, you can also see the vitreous haze has improved slightly in this patient. This is a second example. This was a different dose. These are patients from the stop uveitis study that we did. And again, we saw a decrease in macular edema with the treatment in this patient. So OCT is very, very useful in tracking these patients over a period of time. As I mentioned in the second scenario, we looked to characterize some lesions. This is our multifocal choroiditis patients. Most of the lesions are outside the arcade. This is another example that we would see on fundus photos for PIC and fluorescein. What do we look for in, so when we look at OCT, usually when I used to do clinics with Quan, some of the lesions we had to very elaborately, like we write notes on each lesion. And we would look for RPE elevation, RPE disruption, ISOS, whether it's intact or elevated, disrupted, and then some choroidal hyperreflectivity. The reason we do this or characterize the lesion in this way is because we've seen that in MFC, it's more choroidal changes that we see in these lesions compared to PIC, where 30% of our lesions that we've seen in the PIC patients only show choroidal changes. Similarly, we see that the ISOS is intact but elevated in most of the PIC lesions that we see. This is an example of ISOS, which is nowadays called ellipsoid zone, which is elevated but is intact. The RPE is slightly elevated as well. The example of ISOS and RPE disruption. Of course, you'll have to really look for these lesions. An example of choroidal hyperreflectivity. This is a lesion from a patient with MFC showing RPE and photoreceptor changes. And as you can see, we do not see anything in the choroid at this point in time. This is another example. These are two lesions from a PIC patient showing RPE and photoreceptor changes, photoreceptor layer changes in both lesions. This is a punched out lesion from an MFC patient, and as you can see, once you see this punching out and sort of slight thinning, this hyperreflectivity that you see over here basically means that there are multiple disruptions in the RPE, and the light is actually now passing through the RPE. So whether this is uveitis, or you can see this in retina clinic as well in your AMD, geographic atrophy, and dry AMD patients, where this is called a window defect on OCT. Again, a lesion from a patient with PIC, which has hyperreflectivity in inner choroid. With therapy, these may go away. We've seen in a lot of these PIC and MFC or white dot syndrome patients that they may go away. So if you document it in a visit and 3 months later with therapy they have gone away, or if they have encroached, initially they were only intraretinal and now in the choroid, meaning the patient's lesions are progressing. Lastly, there were some patients who would not have any lesions in the eye, and we would see some thinning, but we weren't sure where the thinning was coming from. So we started segmenting different layers of the retina and tried to compare it with a normative age-matched